when you start. After you.
Okay. So good evening, everyone. We are doing this series of lectures being given by Dr. Roop Gursahani. Basically, it is an understanding about some of the neurological diseases that we come across. Where we have to do palliative care in non-oncology is as important or even more than in oncology, and a bulk of the patients would be neurological disorders. So we requested, me and Gayatri and a few others requested Dr. Roop to take this series. He's started, and we've had talks on motor neuron disease and Parkinson's. And today Dr. Roop will be talking on dementia. There are a lot of people who have joined this time, I think, who were not there last time. So for those of you who don't know Dr. Roop Gursahani, he's a consultant neurologist and epileptologist, as you can see, in PD National Hinduja Hospital, one of the foremost hospitals in Mumbai. He is extremely, he's a very astute sort of clinician, and he's an excellent teacher. And his one big passion, of course, is palliative care in neurology. And to this end, he tries to bring palliative care to the neurology profession, and he brings so much of knowledge of neurology to us in palliative medicine. So with those words, may I hand over to Dr. Roop to start this talk on palliative care essentials in dementia.
Thank you, Joyita. Thank you, Joyita, Gayatri, Savita, everybody who kind of told me to go for this. So palliative care essentials in dementia, and I'm showing the slide yet again. Do palliative care physicians need to learn neurology? Yes, the bulk of non-onco PC is neurologic. But I actually didn't have any documentation for this. And then I ran into this paper as I was preparing for this talk. And this comes from Kerala, the first home-based palliative care unit in Malappuram. And they looked at their registrations over the years. And as you can see, the proportion of...
clear.
Are you clear? Am I clear? Hello?
Yes, to us you are clear. I can hear you clearly.
Okay. So in the initial years, you can see almost 90% of their work was oncology. But in the last segment that they have displayed, you can see that oncology has dropped to just about 30%. And the rest, the bulk of the rest is everything else. Now, this obviously is a study that has been, a classification that has been put together by a palliative care team. And since there really hasn't been any involvement, as I can see, of neurologists, my own feeling is that if you were to split these diagnoses up, neurologic symptoms would probably comprise an even higher proportion. But even otherwise, if you look at what they have in the registrations from 2013 to 15, total of 551, cancer 151, CVA and dementia related actually already outweighs cancer. And so that tells you where your work will go if you move to taking patients from the community. I wish there was a more granular kind of assessment of these needs, but I presume that that documentation will come. And I would like to remind all of you that this is probably unique. There is nowhere else.
Roop, can I just ask you if you would mute or make me the co-host so I can...
Yeah, I'll just do that. I'll just do that. I think I'll make you the co-host so that you can run this.
Till then, I request everybody to please remain muted. We'll have time for questions later. So please.
No, it's much easier if I...
Right. Okay. So then you do that.
No, I'm making you the co-host. I've made you the co-host. There you are.
Okay. Okay.
Done. Yeah. So then, yeah, you can.
Yeah,
take
I'll do that. Sure.
Yeah. Thanks. Right. Where's my screen share gone? So back again. Right. So let's move on. Okay, we saw the slide last time, and if you remember, these are all the various neurodegenerative diseases in the various parts of the brain that you can think of.
It's not come up yet, the
Oh.
screen share.
Slide not there, Roop.
Okay, let me go back and do it. Now?
Not yet.
Oh, yeah, I think something must have gone off when we did this. So let me go back, open the presentation again. And so give me a minute. Yes. Yeah, I'm restarting. Now?
Yes, coming up. Coming up.
Yeah, no, I have to play it. So then it'll show. Play slideshow. Got it?
Yes.
Okay. Okay. Right. So you can see all the various diseases that we have to deal with. We've already dealt with ALS, PD, and today it's the turn of dementia. But dementia is not just Alzheimer's disease. There are other types as well, and we'll come to that a little later. Yeah, here it is. So Alzheimer's disease constitutes a bulk of patients who have a clear-cut diagnosis of dementia, but it constitutes only about 50%. There's a large bulk of it which is vascular, and there is a large overlap between vascular and Alzheimer's disease. So you will have patients who have had minor strokes and then continue to deteriorate even though they don't get any further strokes. Lewy body dementia, we spoke a little bit about it last time. It's a condition which also progresses but has very prominent visual hallucinations. And frontotemporal dementias usually are earlier in onset. And the problem is that the most common variant has huge behavioral problems that families have to manage. But dementia is also, and as palliative care understands, is also about the person. And probably the most poignant image that I can remember in all these, in all this literature, is by this Dutch artist who literally documented his slide into dementia. 6 self-portraits from the age of 60 when he was diagnosed till just before his death. But there is a bigger question, and this question is actually for all of us. There's something to do with Alzheimer. Is Alzheimer a disease, or is it just aging of the brain that goes beyond a point? In fact, there's some question about whether it is entropy, the fact that everything, that effectively from dust we come and to dust we return. Hypothetically, in some way, depending on age, depending on risk factors, depending on cognitive reserve, cognitive decline is something that is probably there in all our futures. In fact, the basic question is, will I get demented before I die, or will I die before I get demented? Not a very pleasant question to ask you, but there it is. Okay. So at this stage, the current research status that we have, and this diagram, if I can work my pointer, if I can't, I'm sorry, it doesn't seem to be working on this particular presentation. If you see, look at these curves. There are 2 curves right at the top, which go up pretty sharply and then stay level. This is the CSF tau, I mean, this marks out the pathology that is occurring in the brain. It, although it levels off, you can see that the other markers, the PET scan, which shows metabolic function in the brain, on the MRI, stuff like volumes in the brain, especially at the hippocampus. Then actual cognitive performance. These all are curves that lag much later. So what does this mean? It means that way before somebody can actually be diagnosed with Alzheimer's, the markers of this are already available. And this is pretty important because if we are going to look at trials and treatments that can prevent Alzheimer's from progressing, then you have to intervene at the stage where it is preclinical. Now, mild MCI refers to mild cognitive impairment. Early and late mild cognitive impairment start off years before clinical dementia occurs. And it has been seen that in at least a couple of longitudinal studies where they looked at communities of senior citizens and did psychometric indices, that the people who were to eventually get dementia actually started showing differences from the controls as much as a decade before clinical dementia set in. And that led us to define a condition called mild cognitive impairment. Now, this is where somebody voices a concern because there's a change in cognition which is reported either by the patient or a family member or even observed by the clinician, which is objective in the sense that one or more cognitive domains, especially memory, shows impairment. But this is a completely independent individual and does not satisfy the criteria for dementia. We'll not get into that, but dementia, as you will see, is a much bigger story than just memory loss. And at this stage, the priorities are to rule out other causes of cognitive decline, monitor them for longitudinal decline. And if it is an early onset story, then look at Alzheimer's disease genetic factors if they are relevant. But the point is that this is where the business of the neurologist who takes on a kind of a palliative care role actually begins. It's possible that palliative care physicians are far from being involved at this stage, but for me as a neurologist, my palliative care hat comes on at this stage. So when I diagnose MCI, my duties are to counsel this patient because they have to plan for the future. I'll come to professional issues and to driving. Now, I don't need to tell you about advanced care planning. It's a process that supports adults at any age or stage of health in understanding and sharing their personal values, life goals, and preferences regarding future medical care to help ensure that they receive medical care that is consistent with their values, goals, and preferences during serious and chronic illness. Does this remind you of a definition? Yes, this reminds you of the palliative care definition. It's a pretty long definition which encompasses everything that comes into it. And it has basically three major components. Actually, two. The first is identification and appointment of a healthcare power of attorney. And the second are the goals of care and medical orders for life supporting treatments that come as part of the advanced medical directive. It's important to understand that as far as I can see, advanced care planning is to palliative care what palliative care is to the rest of medicine. Most palliative care professionals aren't too involved with ACP, or part of it, of course, is because for a long time we did not have legislative sanction for this, but we now have at least court sanction for this, and I think it is about time that palliative care professionals started to get involved in this, because it is very much within the remit of palliative care. And how does this come up? This actually brings me to something that is not very comfortable being discussed in a palliative care group, and that is the question of physician-assisted death or medical aided dying. This was a conversation that I had some time ago in a patient where I actually made a diagnosis of MCI. And he promptly asked me about, can I opt for active euthanasia? I said, I don't think it is legal. It is not going to be legal in India for quite some time. And please remember that when you, if and when you do end into dementia, that person that you are at that time may be fairly comfortable. It may not be as bad as you think it is. And he said it very clearly. He said, my future self may be happy to have his bum clean for him, but today the thought just horrifies me. And if you look at preemptive suicide at the initial part of a diagnosis in Alzheimer's disease, apparently the few cases that are recorded are those of doctors. But the problem with physician-assisted dying in Alzheimer's disease is that Alzheimer's disease is not in that sense recognized as a terminal disease. And in those countries where PAD is done, it requires final consent with a sound mind, which means that the point at which somebody is in moderate or maybe even advanced dementia, they no longer have the sound mind which can consent to PAD. And some of you may be aware that there was recently the court trial of a Dutch physician who completed PAD in a patient with dementia, where the patient visibly resisted. And that physician was charged with murder, but eventually in the final trial, she was acquitted because the patient's original orders were very clear. If any of you is interested, this actually brings us to a very, very complex ethical situation about how does this kind of consent be given. And this story, I'm not going to dwell too much on it because this was a psychologist who made this decision and actually was, prompted by her family, as she has insisted, in completing the PAD. And the ethical decision here was discussed by an ethicist by the name of Dworkin, who said that her experiential interests, in which when she still was living a good life, were superseded by her critical interests. And what this means is that if you as an individual are the author of the story of your life, then the role that you have at the prime of it supersedes, obviously it supersedes what you are as a child and what you are as a demented individual. You have the right to write it. Again, as I said, this is not something that is very comfortable for palliative care physicians to discuss, but if and when neurologists are involved in it, this is becoming a bigger and bigger issue for us. Why am I moving on to professional issues here? Well, this is my dad. And in fact, this picture was taken a year before I was able to diagnose dementia in him. And at this stage, he was in the process of closing down his practice at the age of about 82. He was a lawyer. So you can understand that when these issues come up, when somebody has Alzheimer's disease in their brain, perhaps are heading into cognitive decline, which are the two professions that are going to be hit by this? Lawyers and doctors. And these are situations that are most likely to arise in countries like the US and India, where we have private practice, because we determine when we stop practice. Unlike, say, for instance, countries where you have universal healthcare, where there are limits to how long you can practice, until what age you can practice. So if anybody is interested, this article in the NEGM discusses this. But these are guidelines that were put up soon after that, especially for the US. And this is something that I keep in mind, because I've already seen two of my senior colleagues heading down this way. So the first is, if you see something, say something, have an available assessment program. You have to remediate when possible, but facilitate retirement when necessary, if need be, by informing your hospital authorities and so on. And ease and improve the process of retirement, because not everybody, even after the diagnosis of Alzheimer's, needs to stop practice immediately. This is because my dad, now when he stopped practice, and to the point that I made the diagnosed dementia, the difference was just about a year. So, and if I know, he was probably already in mild or early moderate dementia at the time that he stopped his practice. And he was able to close down his practice pretty smoothly. I had no complaints, heard nothing at all. So obviously, he was able to function and he could manage this. And this is an issue that will face all of us. The other issue that comes up is that of driving. And here, again, people who have dementia will have problems with managing visual inputs, and they will require regular certification, maybe annual or even less. Now, once somebody is diagnosed with dementia, that initial period in, if you remember that earlier stage of preclinical, leave that aside. We are now talking of clinical onset of dementia. The whole period can be as long as 2 decades. The mild stage, when people are functional, the moderate stage where dependence increases, and the terminal stage where people lose ability to perform even basic activities of daily living. Now, when you assess activities of daily living, typically families seem to recognize this only when basic activities of daily living are impaired, like bathing, dressing, when somebody starts occasionally having toilet accidents. But if you look back at their history, you will find that instrumented activities of daily living refer to our ability to use our environment. We are people who live in an environment which is largely socially determined. So for instance, these are 4 activities which are effectively gender neutral. So for instance, if you look at telephone use, so from an individual who probably has a phone book of say 400 people of acquaintances or so on, this person gradually shrinks to dialing only a few numbers, eventually reduces it to only receiving calls, and then finally conversation also declines. And yet families don't recognize this decline until the person literally stops speaking too much, because it happens so gradually. And it's only when, as a neurologist, I trace it out, that I realize that this was an individual who stopped dialing numbers, asking his family to dial it, stopped traveling outside, maybe even using a rickshaw, stopped managing his own medications, starting to require a pill box, and gave up, his checkbook and other things which would have been so important to him, at least a few years before the basic activities of daily living decline. So as somebody starts to progress, now the MMSE is a mini mental examination which we all of us use, and I'm not going to take you through the various components of it, but you will realize that most patients, and it's pretty simple to do if you do choose to do it, should be scoring full 30 marks. As it begins to decline, you can actually numerically trace the decline of that individual. Typically, till about 20 or so, it's basically word finding, name finding, forgetting people's names. Then they start to withdraw from activities that they could comfortably do. Typically, this is a time when they start to lose their way around the house, maybe make mistakes dressing. Say, for instance, somebody who would choose what clothes to wear now occasionally wears the same shirt again and again, or tries to wear a shirt and puts it on his leg or things like that. And then beyond that, they start to lose the ability to care for oneself. And that's when all basic activities of daily living are supported. Uh, uh, we call this early, mild to moderate, and severe dementia. So in severe dementia, the MMSE would be below 12 or 10. These are not very clearly defined numerical values because they also depend on other factors. But these are individuals who no longer can take care of themselves. So when somebody heads into definite dementia and they have to, they and the family have to begin living with dementia, other issues come up. The first is unfinished business. And this unfinished business typically refers to legal issues, wills, advanced care planning. Then behavioral and psychiatric symptoms begin to appear. Anxiety is very common right in the beginning, and depression also is pretty prominent. But as time goes along, they have other issues that come up. There is a risk of abuse, and that's on both sides. The patient can be abused and the patient can be the abuser. And obviously, you're looking at a long spell of caregiving for the family. Now, when somebody has to make major decisions, this is called assessment of decision-making capacity. Not many neurologists are comfortable with this, but it is something that we should be able to do. This is basically done in two stages. The first stage is assessing the severity of cognitive impairment, and this uses the instruments that I told you about. Obviously, this may not be the job of a palliative care physician, but you need to be aware that the MMSE, and it's a pretty simple instrument if you ever choose to see it. Up to the stage of early dementia, which is MMSE greater than 24, they are entitled and capable of making their own decisions about almost everything. Early dementia, which stretches, as I said, from about 24 to somewhere between 12 and 16, values remain intact, but you may need to be a little careful about using a dementia-specific tool in case you're making end-of-life care decisions. Could you make a will with these patients? Estate will? Yes. For instance, I have made a proper will of property and everything with a patient whose MMSE was 18, which means he was well into moderate dementia. But below, say, below 16 and definitely below 12, the ability to understand and appreciate will decline. Though it has been said that end-of-life decisions can still be discussed at this point. And if you need to assess this kind of an individual for decision-making capacity, you have to assess them. This is for the patients who are in moderate dementia, is to apply these 4 tests to whatever it is that you're assessing them for. So if they are making an estate will, do they understand what this is about? Do they appreciate how this information that they are discussing, how does this apply to them? Of course, this I had done for a script on advanced care planning, but the same will be used for the standard will. If they give so-and-so property or so-and-so money to one individual, do they understand what it means to the other individual? And if they can take a decision, can they actually state it? If they pass these 4 tests, then worldwide it is accepted that their decision-making capacity, at least to that particular instrument, is intact. Okay. Now, as an individual starts to progress through Alzheimer's disease, typically cognitive functioning measures deteriorate, functional autonomy deteriorates, and eventually motor function deteriorates. But if you look at psychiatric issues that come up, mood is the first thing that changes, and it deteriorates very early in mild and then moderate dementia. It is because there is a certain amount of preserved insight at this stage, and an individual who knows what is happening, or who can literally feel the lights going out, is bound to be both anxious and depressed. But over a period of time, this settles down, and the more difficult behavior symptoms then start to emerge. Now, these behavioral and psychiatric symptoms span the range from delusions, hallucinations, euphoria, aggression, apathy, irritability, disinhibition. Disinhibition would be, including sexual behavior. Wandering. Now, wandering is a very difficult symptom for families to handle. So suddenly they will realize that the individual wakes up at 2 or 3 in the morning, opens the door and is gone. And individuals have gotten lost. Pacing, they walk up and down continuously, and then sleep disturbances. So if you do have a patient in moderate or severe dementia, you specifically need to screen for these symptoms by asking if there are behaviors that worry the caregiver, are there hallucinations, and more importantly, how is everybody sleeping at night? Now, agitation is the one that really worries everybody. And if it is new or worsening agitation in a patient with dementia, the first priority is to assess risk of harm to self and others. And obviously, you implement safety strategies, see that there is adequate caregiver support. If there is a severe risk of harm, then you may need to start short-term drug treatment. And here, if you remember, last time we spoke about people with Parkinson's, where you would not use haloperidol or standard or our antipsychotics. Here, antipsychotics can be used. And typically, I would probably put them on a prescription for haloperidol anywhere between 0.25 and 0.5 milligrams 3 times a day, maybe going even up to higher doses in case the agitation is uncontrolled. And then sometimes these patients even need to be admitted. As you can imagine, and I don't need to tell a palliative care audience about what to be done, how do you assess for people who are delirious or agitated. Remember that you have to look for medical illnesses, medication side effects, especially if new medications have been added. You have to assess for pain, and we'll be discussing that a little later. Some of these patients may have been depressed earlier, and you can still try out an antidepressant at this site. Sleep disorders are prominent, and it is important to review their sleep hygiene, enforce a consistent sleep-wake schedule, maximize morning light exposure. So I'm sorry, I've not got a slide here. There are 3 things that I do at this point. I ask the families to make sure that in the morning, the individual is sat out in bright light. As far as possible, if they can sit for half an hour and an hour in the sunlight, that's good. I might use an alerting drug in the morning if need be, and add melatonin, 3 to 6 milligrams at about 8 p.m. And this combination of 3 measures often returns their sleep-wake cycles to normal. And then don't forget sensory deficits. These are older people whose vision may be impaired, whose hearing may be impaired. It could be something as simple as a cataract that people have forgotten to address, or wax in the ears. And basic examination will pick these things up. If there is pain, and this scale is not really for people with moderate dementia, because at this stage they would still be able to communicate. This is for advanced dementia. These are people who are close to non-verbal at this stage, and you will be looking at things like breathing, negative vocalization, which would mean moans, groans, and so on, changed facial expression, body language, where they are, if somebody is in real pain, they'll be rigid, they will resist any kind of intervention. And very often, these patients who are distressed, if the distress is not caused by pain, if it is not caused by any of the previous elements that I told you about, very often this can be handled by touch, by consoling, by and there are measures that are being used for this. There is another problem in this behavioral issues that I think I forgot to cover in a slide, and that is called disruptive vocalization. You will have individuals who will cry or howl loudly and continuously. And here again, obviously, you do all this assessment, but some of these patients actually respond to the intervention that I'm coming to a little later. Of course, if the symptoms are persistent, if there are prominent psychotic symptoms, especially delusions, I mean, they are pointing to people and trying to hit imaginary people and so on, you might need to, as I said, consider short-term drug treatment. The family needs to be guided how to handle this. If they are in an environment where you can manage things, then enhancing lighting, reducing noise levels, caregiver support and respite, all of these will help. Now, this brings me to the issue of the caregiver. And here, especially in neurology, I think that we need to use our terminology a little more carefully. You will have noticed that in some papers, people now talk of the care partner. And I actually separate these three roles out, at least in my own practice. The care partner is effectively the individual who supports the patient, but the patient still has autonomy and is able to largely make her own decisions about treatment or whatever. And that is why the care partner is there mainly as a supportive individual. As the person's ability declines, as autonomy is lost, the caregiver emerges. And very often you see that the care partner originally was a spouse and the caregiver then is an adult child. And of course, fortunately in India, we still, at least for the middle class, we still do have access to paid caretakers. And that is why I said I separate these three terms out, at least for my own purposes. But very often the family is the caregiver. They need information about the diagnosis and prognosis. They need assistance in dealing with the symptoms. They need assistance in dealing with their own feelings of inadequacy, guilt, and so on. The personal impact of caring, especially in a patient with Alzheimer's, where it can go on for a decade, is huge. And you need to recognize this. There has to be guidance about coping strategies. And for me as a neurologist, learning this has been also something important. I now know that I must recognize the caregiver as well, part of my responsibility. And I do make that explicit to the caregiver, like recognize them by name, ask them how they are doing, and so on. Now, I'll drop this. I think this was okay. Then comes the question of, at some stage beyond moderate dementia, as the dependence increases. This slide is complex, but because it is meant to be complex. You are used to using simple instruments such as the surprise question for oncology. This doesn't work so well in dementia. If you look at predictive models, this is a complicated mathematical model which has 18 variables, each of them, some of them with 6 or 8 sub-variables within it, to actually give you a good mathematical understanding of prediction. And this is not a model that's been tested in real life. What has been tested are these, and these are fairly simple. And I'll also come to the other one that we do use, the gold standards framework. I'll come to this. But this is one score which applies to basically to all medical illnesses. But if you look at this, you see the in step 1, and a male individual who requires assistance with all basic activities of daily living will have a score of 6. And anybody with 6 points has a 1-year mortality of 30%. If they have any other comorbidities, which is quite likely, they cross 6 points, their mortality within 1 year is over 60%. And it is something that has to be explained to families that an individual with a mortality of 60% in 1 year is extremely unlikely to survive beyond about 3 or 4 years. But the gold standards framework, the triggers that indicate that somebody is entering a later stage are loss of ability to walk, incontinence, loss of activities of daily living, and the Barthel score. The Barthel score, I'll discuss that a little later. It's in the next slide. Plus any of the following: weight loss, recent weight loss, urinary tract infection, pressure sores, reduced oral intake, or an episode of aspiration pneumonia. This is when you know that survival is typically within about 6 months. The staging that we use most often is the fast staging. And you will recognize 1, 2, 3, 4, 5. These are pretty much simple. They take you through mild to moderate dementia. But it is 6 where somebody starts to lose basic activities of daily living, and 7 that you actually start to think in terms of end of life care. And although this is 7 is listed as A, B, C, D, E, F, these are often not sequential. So ability to speak gradually goes down to basically a single word. Ambulatory ability goes down. They cannot sit up without assistance. And eventually ability to smile and ability to hold head up is lost. And this is about the stage at which swallowing also starts to get impaired. Now, sorry, I'll just have to take this call. Sorry. Hello.
Dr. Gursahani?
Yeah.
I'm calling from Meta Medical Center.
Please call me after. Please call me after half an hour. I'm taking a Zoom lecture right now. Half an hour. Yeah. So this is the fast stage, and I suggest that at least 6 and 7 should be part of anybody from palliative care who needs to look after patients with dementia. But for a little more detailed assessment, you have to actually systematically look at the Barthel index of activities of daily living. And it's pretty simple, but you're looking at all these features. So bowels, bladder, grooming, toilet use, mobility, dressing. And if somebody scores more than 3, say, so for instance, they may be incontinent, but if they are, they require, say, the help of only one person to walk, which is, say, in mobility, it is 2, and can feed with 1. So you can get, if somebody scores 4 or 5, then they are probably at least a shade above the immediate hospice stage. But if somebody is in 3 or below, then they are probably already at a stage where swallowing is being impaired. Now, as you go into patients with advanced dementia, their palliative care needs, in addition to the basic needs, still require psychological needs that they still manifest. They require the need for comfort. They need attachment. So being close to family, being recognized by family, being included in the family, all of these are important. The point is, how do you do this systematically? So Namaste Care is a program that originated in the UK, and it is basically has been used in residential nursing homes for patients with severe dementia. And it includes a lot of things like feeding them, but these are all systematic activities that are performed within the home at specified times of the day, and it actually works to the point that it has been that it is now being used in a trial. Sorry, did I have? Yeah, okay, sorry. I had one more slide somewhere here, which actually speaks about an RCT for the Namaste Care program, which is just about beginning here, and it is begun to be expanded elsewhere. I do talk to my to the family caregivers about these possibilities, about structuring activities like this at home. And depending on the capabilities, families do understand, and they are able to perform these. Now, when you are looking at end of life care in somebody with advanced dementia, there are some steps that are essential, both for us as professionals as well as for the patient and family. Planning discussions have to be timely. End of life care, end of life has to be recognized, and supportive care has to be instituted. This care has to be coordinated, and there has to be continuity between, say, day and night and hospital and so on. There has to be liaison with primary care. So, for instance, a GP has to be involved. If not, then you may need liaison elsewhere. In fact, probably one of the major things that needs to be done is to avoid unnecessary admissions by clarifying this with the family. And obviously, bereavement needs to be managed. And staff, especially if you have regular, say, paid caretakers, then they need to be trained. And it is important for us to understand that the skills that we will require for geriatrics, for palliative care, and for dementia care, especially in terms of paid caregivers, probably overlap. And it's about time that that is a skill set that needs to be trained for. Then come decisions that have to be taken at the end of life. And these are now termed heuristic decisions, because these are not decisions that can be put down into an algorithm. And to some extent, they are decisions that are taken based on the individual patient. And they refer to management of life-threatening infection and pneumonia, management of severe pain, agitation, medication rationalization, and obviously DNI, DNR. They do differ from guidelines, and if anybody is interested, there are at least these two free papers which are quite interesting. For instance, if you look at eating or swallowing, this conversation about whether the individual has to be fed artificially or not has to be done in advance, because very often before the patient actually stops swallowing, they have reduced eating, they are more and more fussy, they need food to be mashed and so on. If it happens as an emergency, the patient aspirates, you obviously stop feeding. If the dementia, ongoing dementia, is the cause of the eating or swallowing difficulties, you will need to shift to comfort feeding. If it is a potentially reversible cause, you may think of a time-trialed nasogastric tube, but it is unlikely to be kept for long because the patient is very likely to pull it out. And if you need to go on with it for longer, then, well, the only option is a PEG, that is a percutaneous endoscopic gastrostomy. So these are things that are that you can inform the families to do if they are doing comfort feeding or hand feeding. They have to allow flexibility in eating patterns. It has to be somebody close to the person who will help with the feeding, talk to them. And basically, I tell my families that he or she is now a baby. You feed her like a baby. There is enough evidence that artificial feeding, which means either a rice tube or a PEG tube, does not enhance survival and in fact worsens quality of life. So this recommendation came out some years ago, and this says that careful hand feeding for patients with severe dementia is at least as good as tube feeding for the outcomes of death, aspiration pneumonia, functional status, and patient comfort. Tube feeding is associated with agitation, increased use of restraints, and worsening pressure ulcers. I think that's as clear as can be. If you remember, in motor neuron disease, we encourage early PEG tubes because they help with management of respiration. In patients with Parkinson's, you actually have to take a decision based on the individual patient, because those patients who have much more motor impairment will benefit from a PEG. Those patients who have much more cognitive impairment will not. And you have to choose that. What about agitation? If a patient suddenly becomes agitated, well, you have to find out what has changed, see if there is an environmental cause. If there is no identifiable cause, try analgesia, which is not something that is obvious to people outside the palliative care world. Try massage and so on if that works. As I told you about people who have disruptive or recurrent vocalization. Only after this is done, then a trial of antipsychotic medication. This has to be discussed with the family, because antipsychotics at this stage actually can cause cardiac problems and have been associated with increased rate of death. What about ending life-sustaining treatment? If the person has already been put on, say, something like has been intubated. And here you need to discuss this with the family and stop treatments one at a time. You also need to discuss with the family or the advocate what is an acceptable level of care. See if it is best suited to that person's needs. Identify the goal of maintaining comfort and dignity. And in some ways, you make these adaptations at a regular basis. And this discussion needs to be ongoing. So I'm just going to finish with summarizing what are the issues that come up in patients with dementia. In mild or early dementia, it's advanced directives, identifying healthcare power of attorney, treatment of depression, medications for cognitive symptoms. I didn't really discuss this because these are drugs like anticholinesterases and so on, which we use for mild and moderate dementia, but usually withdraw in severe dementia. And obviously the beginning of caregiver assessment and support. In moderate dementia, you need to screen and treat for behavioral and psychiatric symptoms, do safety evaluation, increase caregiver support, and assess care needs and the setting in which the patient will be taken care of. And in severe dementia, you are looking at end-of-life care. These are patients who have decreased ability to ambulate, who can have choking and dysphagia. Deprescribing medications is important, and obviously they will need formal palliative care reference at this time. I'm going to stop at this point and take questions. I'm stopping screen sharing, and I suppose I will now see my audience. Thank you. Okay.
Thank you very much, Roop. That was again quite comprehensive, and you covered the palliative care aspects really, really well. And at the beginning about the biological basis and the pre-symptomatic and early and then late dementia. So there are lots of questions. So let's get started
Okay.
One by one. One is that is it mandatory that all eventually will get dementia? And how much does lifestyle and life stance influence the course of dementia or the onset?
That's an existential question. So yeah, if you stay active, it's I mean, there's enough evidence now that moderate exercise is probably the best way to prevent. And beyond that, it's early life cognitive reserve. It's basically education and so on that adds to that. There's a fair amount of research that goes on, and much of that is in the public domain. But if there are any clear indicator, it is that you have to stay active and you have to keep using your brain.
And plus the family history, I guess, if there is a family history.
So on that count, I already have one hit against me.
That's fine. So any advantage in diagnosing Alzheimer's early, and any way for slowing progress or reversing?
Okay, so at this moment, it's only in people who have a genetic basis that you would use the various other tests that are used. So for instance, amyloid imaging and so on. And these are techniques which are not available in India. We do have FDG PET, but there is a PET imaging which is directly done for amyloid, which can actually see the burden of amyloid that you have in your brain. And that is still not available in India. So also the CSF tests, the blood tests to look at amyloid and tau, no, they're not available in India at the moment. The only test that we have is to look at hippocampus volume on the MRI. I am not sure it's of much clinical use at the moment. The reason for doing all of these is, well, to identify patients for trials, which tells you that there is no real treatment at the moment.
So I just have one question related to what you just said. So when is the time to break the bad news about the diagnosis? Because we don't have these investigations to fall back on and say that this scan shows this. So when would you do that?
So the patient would come to you in mild cognitive impairment. They will come to you with memory impairment. This memory impairment can be confirmed by a psychometric examination and with basic investigations. So something like an MRI would rule out, and a basic workup would rule out other causes. Once you've done that and the memory impairment is confirmed by psychometry, by the patient, and by an informant, then you have the diagnosis of mild cognitive impairment. And for somebody who is, say, in the 60s or beyond, the rate of conversion to actual dementia is probably of the range of between 5 to 10% per year.
Right. What is the time frame for making a will as part of the advanced care planning? I know you said it, but the estate will, but any time frame?
For both the estate will and for advanced care planning, you can well do it into moderate dementia. If they have only mild cognitive impairment, for that the MMSE cutoff is 24. Some people take as 26, but 24 is the cutoff that all of us take. Anyone who scores about 24 can be certified as fit to do both these activities. Below 24, you would need either a neurologist, a psychologist, or a psychiatrist to actually specifically take the patient through that instrument and certify the patient as having completed the instrument adequately.
Sure. And any extracurricular activities can be suggested. You said about moderate exercise, but
people suggest Sudoku and crossword puzzles and all that, but I think moderate exercise is probably the only thing that has been documented.
Okay. And is PayNet free to use?
Sorry?
PayNet free to use?
I think so. I saw that. I mean, it's not a charged instrument.
Okay.
It's available on multiple sites. I downloaded it just like that.
Yeah. And that was a very nice concept of your caregiver, caretaker, and care partner. Would you please just explain it once more? Because
okay. So the classic prototype for this is a patient with dementia. A patient with dementia at the onset with only mild impairment typically will be autonomous and will make his or her own decisions. And at that stage, if at all they need support, it's a care partner. Okay, somebody who accompanies them to appointments and kind of monitors stuff and helps them. As they become dependent, then the person who takes care of them becomes more of a caregiver. Okay, and typically this would still be a family caregiver. When I refer to a caretaker, I look on that as a paid caretaker. This would be an orderly or a ward boy who comes in. So this is the scheme that I use for my own patients so that I know whom I'm referring to when I'm.
Right. That's quite useful actually, because so many times that caregiver and caretakers are used so interchangeably and we don't really know.
And professional caregivers.
Yeah.
We are also caregivers.
Caregivers. So
that's I kind of separate these things out.
Yeah. One more question on what is the latest pharmacological management in Alzheimer's?
Okay. So the two drugs that I use most commonly, there are three actually that are available. These are the anticholinesterase inhibitors. Sorry, I should have included a slide on them. They are rivastigmine, donepezil, and galantamine. These are the anticholinesterase inhibitors. These increase acetylcholine in the brain, and they kind of help the brain function better in terms of memory, but they don't alter the process. Then there is a drug called memantine. It's a drug which is supposed to antagonize NMDA and reduce the degeneration. But again, these are effects that have been shown in trials. In an individual patient, you might not find them very effective at all. I usually will give a patient a trial of donepezil and or rivastigmine. You can't give both of them together. It's usually only one. And you have to remember that at the later stages, that they can cause cardiac issues. So in severe dementia, it is probably best to withdraw them.
Right. And any sort of guidelines on antibiotic use or in, respiratory or UTIs in dementia?
Okay. So in severe dementia, these decisions become heuristic, and they will have to be individualized in the patient. So for instance, would you use IV antibiotics? Would you use oral antibiotics? I mean, in somebody who's already immobile and ends up developing an aspiration pneumonia, you might just start an oral antibiotic and shift to comfort measures only. Or if the individual is not able to swallow, then maybe you would not, put an IV line to give IV antibiotics. So these decisions are heuristic decisions, and there really cannot be a single algorithm for every decision that you take. So you have to contextualize these decisions.
Right. That's good to know, because that's so practical. Any official consensus on palliative care in dementia?
Abroad, I mean, you'll see the literature is huge. There's a fair amount of understanding that palliative care needs to be involved more and more. Last year was the first conference that I'm aware of for palliative care for dementia. It was held in Ireland. Unfortunately, I got to know of it too late. But hopefully in the next year or two, it will become maybe a biannual feature. And it's coming up. And if you look at the numbers, there is no way that palliative care can be kept out of it.
Yeah, right. Anything about vaccinations?
For?
In dementia. I'm...
Oh, sorry. Again, yes. So again, like all vulnerable individuals and older individuals, yes, you probably do need to give them the flu vaccine and pneumococcal vaccine once they are in moderate dementia. Yeah.
So just coming back to drugs for 2 minutes, any role for citicoline?
No.
Okay.
Rubbish.
Okay. And somebody has rightly said that beta secretase inhibitors have not been developed. So all the theory is quite good, but all the beta secretase and the gamma secretase inhibitors look all very good on theory in the cause and the tangles and the plaques, but I guess we haven't really gone there. So that is there. And just wanted to say that the role for pharmacological management is really in the early stages, because that is the only way to sort of slow the progress. Once it has gone over moderate, then it is going to be difficult. Saurabh wanted to know whether these lectures will be available on any link to these lectures. So if we can...
I'm not sure. It has been recorded, so I'm happy to share the download link. I'm not sure it's going up on YouTube.
No, not on YouTube, but maybe whoever
this has been recorded. This has been recorded.
Yeah, this is recorded.
And
sorry.
Anybody who writes to me, I'm happy to share my slides. Not a problem.
Okay. And the other thing was about, is there any training? Because you said about the caretakers and the professionals, sort of attendants and ward boys, any sort of training program for these ward boys? I think there is on the chat that there is TISS and SNDT have a program for the training people for as general caregivers. I think I don't think it is for caretakers, not necessarily for dementia. And also the Alzheimer's Society, the ARTSI is a great society to refer to. So that is for the support. And I just wanted to ask, because this comes up, you said MMSC, but is there any change in sort of MMSC use guidelines in that MMSC that you have to pay for it now?
So the MMSC is, if you use it for an individual patient, you can still download and use it. But if you use it for for any kind of research purposes, then you are supposed to pay for it. So most of us now use the MOCA.
Yeah.
Most of the old, that's the Montreal Cognitive Assessment, that is free to use. And it's also pretty easy to use. It doesn't require much training. But for palliative care physicians, I think understanding activities of daily living, so either the Bathel Index or the ADL, of course the ADL is a little more complicated, or fast aging. Between the two of them, I think you are good to manage patients with dementia from moderate stage onwards. I think if at all you need to look at two scales, these are the two scales. I didn't cover the IPOS-DEM. That's a recently developed scale for palliative care needs in dementia. It's not fully validated yet, but it's being used more and more often, and that is probably going to be the scale that all of us will need to get familiar with. IPOS, IPOS-DEM.
Yeah.
I mean, if you look at the website for IPOS-DEM, you need to log in, register, and do other things before you can actually use it. So if you need it for a research purpose, then that's probably the one to use.
So on the MOCA, Lena asked a question whether it's available in local languages and
countries. Yeah, it's been gradually being translated into more and more. I know it's available in Hindi at least.
Yes, that it is. And there's a question on, is it easy to differentiate dementia and Alzheimer as management may differ? We mean that dementia due to other causes and dementia due to Alzheimer's is what I'm presuming.
Yes, I mean, it's not terribly difficult if you do a careful neuropsychology. This is because if you looked at the other diagnosis I gave you, so if somebody has a frontal lobe dementia, then they lose frontal lobe function, which is executive abilities, behavior control, and so on. But they are still pretty much functional in other things. And in fact, they become very disruptive. Whereas somebody who's got Alzheimer's starts to lose overall functioning. Now, when you do a careful neuropsychology, it's like, you know, this part of the brain is affected, that part of the brain. You can make this distinction. So it's a clinical distinction and it can be done.
So can I just ask, because you mentioned neuropsychology, is there a sort of bare essential kit for neuropsychology to be done apart from the MMSC? That will be the trigger, but what else?
So the MMSC is one. MMSC and the other equivalent is the MOCA. These two are scales that can be used by anyone. They don't require training, maybe a little bit of practice. And the next one that we use most commonly is the Addenbrooke Cognitive Examination, the ACE. So MOCA and MMSC are about 30 points. They extend the MMSC and add some more points to it. The ACE goes up to 100 points. And it's a much more granular kind of a assessment.
So that dementia question, it was a differentiating dementia, Alzheimer's from senile dementia.
There is no real difference. There is no real difference. Senile dementia is Alzheimer's.
Yeah, right. Okay. And so is there any, this is just my question, is there any time frame in which the imaging, the amyloid PET and the tau PET would be coming?
I think in the next decade they will be available. Well, the thing is that at the moment they are important only for individuals for their own individual decision making. Say, for instance, if I want to find out if I'm going to be demented in the next decade or so, yeah, it would be useful. But without a, a therapeutic intervention, I doubt it would make much sense. Somebody who has developed a mild cognitive impairment, which is documented, where there is no other cause, is Alzheimer's. Is the beginning of Alzheimer's.
So this is my personal, I always wonder about it. Is there any point in all of us keeping a sort of a baseline MRI and ready? So for in case if anything happens in the future, you have a baseline to compare to?
No, not really, because there is a problem there. MRIs are very sensitive. They turn up things that you don't want to see. So if you're absolutely okay and you find something on the MRI, you might end up with treatments that you don't want. And
no, I was just sort of thinking about, those with a family history, those who have all the sort of factors which will lead to a lot of stress, no exercise, presence of diabetes, hypertension, everything.
No guarantee.
Like
It's too unpredictable. So you had people who are completely, I mean, absolutely fit, doing everything. And then, yes, still sliding into dementia. Like that physician he was as fit as they come.
Yeah.
I mean, and he'd been living a really good, virtuous life. And he was so upset when he realized it had begun that you can imagine. I mean, so it's well, you do your best, you do the due diligence, and you hope for it the best.
Right, great. So I think we've covered the questions that have come up. Big thank you to you, Roop, and there are lots of appreciative comments on the chat about how it is being very informative and very practical. So thank you very much. This is in your style, and we learn a lot, and there has been time for a lot of discussion and questions. Hopefully, we've been able to cover all the questions that have been asked. We've learned a few important things about the MMSE, the MOCA, the neuropsych testing, the ACE, for which we will need the psychopharmacology, the great concept of the care partner, caregiver, caretaker, and various training programs, and whatever antibiotic usage and official guidelines, and hope to work more collaboration between neurology, palliative care, psychiatry, everybody else who works for this cause.
Yes.
So that is great. So thank you everybody for joining us today. We have almost 50 participants. So we will meet again next week,
Wednesday for the last one.
Same time. So thank you very much. Thank you.
Bye.
Thank you everyone. Thank you.
Bye. Good night.
Good night.